We'll move on to the next speaker. I'll just reintroduce briefly Professor David Greenfield from Bascom Palmer. David's glaucoma specialist as well as vice chair. What to do about optic disc drusen and co-existent OHTN and glaucoma.
Well, thank you again, Alon. So Sasan is an expert at analyzing funny-looking discs and has a center for myopia and glaucoma, and probably is one of the leaders in being able to differentiate glaucoma in an eye that would otherwise be very difficult and challenging to detect glaucoma. This is an example of such a condition, and these are sometimes referred to as hyaline bodies of the optic nerve or optic nerve head drusen. And it's challenging to uncover the diagnosis of glaucoma, particularly when the intraocular pressure is in the statistically normal range. So the question really becomes one of several topics. And what I'll try to do is discuss specific modalities for uncovering the diagnosis of optic nerve head drusen, and how to establish the diagnosis of glaucoma then in eyes with coexisting optic nerve drusen, and what to do about treatment and monitoring for further progression. So here's an example. This is a patient who has both glaucoma and optic nerve head drusen. Interestingly, in an unrelated systemic finding, I think the patient was treated for a parathyroid tumor, had a diagnosis of elevated serum calcium, and subsequently had surgery to remove the parathyroid tumor. Was treated at Wilmer, not by Pradeep, but by others there for his elevated intraocular pressure, and was found also to have optic nerve head drusen with very good central vision, 20/25, and was using timolol and latanoprost, and had an acceptable pressure somewhere around 15 to 17 millimeters of mercury. And if you look at the optic nerves, they show the very classic lumpy, bumpy pattern of calcification with proteinaceous material buried beneath the surface of the disc, with much more significant visual field abnormalities in his right eye as compared to the left eye. But discs that are hard to interpret for the classic signs of glaucoma. So a number of ways to uncover the diagnosis in this patient. What I'm showing you here is not only the peripapillary nerve fiber layer atrophy on the optic nerve OCT, but also serial cuts that were performed through the optic nerve. And you can see just beneath the surface, there is a sort of ring of hyper-intense circular area, which represents the calcification, and then the well-circumscribed drusenoid lesions just beneath the surface of the disc. So one way to diagnose these certainly are using the OCT and performing radial cuts through the suspected area where the patient might harbor drusen. The one I do more commonly is a fundus autofluorescence image, and very easily, very nicely, you will see the areas of hyper-intense autofluorescence corresponding to the optic nerve head drusen. And then finally, a good echographer will be able to uncover the diagnosis of these hyper-echogenic lesions corresponding to the drusen. So lots of ways to diagnose them, and they will typically manifest in one of two ways. The ones we often see them are illustrated on our right, where that lumpy, bumpy appearance, and they're very easy to detect. The ones that are more challenging are the ones that look like papilledema, but clearly are not associated with elevated intracranial pressure, and this is often referred to as pseudo-papilledema, and can be very concerning, specifically if they're in both eyes and patient would otherwise seem to have papilledema. So I mentioned that diagnosing glaucoma in eyes with coexisting optic nerve head drusen is challenging. I showed you examples where you can't see any of the typical manifestations of glaucomatous cupping or rim thinning, the visual fields. Well, the visual fields typically show nasal depression. And after I completed a glaucoma fellowship, I did a fellowship in neuro-ophthalmology. And I remember during my training, the most common disorders that will cause a nasal visual field defect are glaucoma, 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 and then optic nerve head drusen and elevated intracranial pressure. So intraocular pressure is one of the most important things that we use to be able to differentiate eyes with drusen that do have glaucoma from eyes with drusen that do not have glaucoma, because otherwise it's very hard to know whether or not they're two disorders. So that's how I'll separate this diagnostic approach. Is the pressure in the eye normal, or is the pressure in the eye elevated? So my approach is certainly to employ multimodal imaging and establish the diagnosis of optic nerve head drusen. And then how often to monitor them? Well, that depends on the severity of the visual field loss. And the case that I illustrated earlier, there were significant visual field abnormalities. And in such an eye, it was easy because the patient had a history of baseline pressure elevation. If the baseline pressure was always in the normal range, I'd probably see them anywhere between every 4 months and 6 months initially, and really get a good characterization of their IOP fluctuation to help whether or not to guide treatment. So in these eyes with normal IOP, I don't recommend treatment unless there's progression and there's no evidence that IOP lowering will prevent or reduce the rate of any further visual field progression in these eyes. And that's a different approach from eyes, obviously, with elevated intraocular pressure, where I employ the same multimodal imaging technologies, monitor based on the severity of the visual field loss, and then without any evidence, guidelines employ a strategy to get the intraocular pressure around 30% lower than the baseline level, and then follow very closely for progression, which really becomes the most challenging part of following such patients, because not only does glaucoma produce changes in both the visual field and the optic nerve appearance, but obviously optic nerve head drusen will also produce changes in the visual field. And it becomes very, very challenging to differentiate the changes that are due to the nerve head drusen from those that are due to glaucoma. So Sasan, I leave it up to you for your next project to tell me, using ROTA, whether or not there are any specific strategies that can help all of us try to differentiate the changes in the visual field that might be associated with one versus another. So in summary, use various multimodal imaging technologies to diagnose it. I happen to like autofluorescence. You really have to identify high-risk characteristics for glaucoma, such as eyes that may have had prior LASIK, in whom the central corneal thickness might be causing the intraocular pressure to be artificially low, family history of glaucoma, et cetera, and eyes that do have elevated pressure. I try to achieve about a 30% target lowering, advancing the treatment in eyes with further visual field progression. And I've really very, very rarely required any surgical IOP lowering in such eyes. So that's a good thing. Thanks very much for your attention.